Hello, my name is Nathan Wong, and I'm the editor-in-chief of the new Cardiometabolic Disease Clinical Community, which is available on CardioSource. Today, I'm talking with Dr. Khurram Nasir, a preventive cardiologist from Baptist Healthcare in Miami and assistant professor at Johns Hopkins, on the topic of the use of coronary calcium screening to identify the need for lipid-lowering therapy. Welcome, Dr. Nasir.
Hi, Nathan. It's a pleasure to be on board.
So your research consortium has been at the forefront highlighting the limitations of traditional risk factor-based approaches for risk stratifying asymptomatic individuals for future cardiovascular disease. In your opinion, what are the key limitations of these current paradigms for risk assessment in the primary CVD setting?
Well, Nathan, thank you so much for the opportunity for highlighting, I think, a key issue that has been the core of our investigative efforts for many years. So one question that I have always been very interested is that while we have been extremely successful in reducing the risk of dying after a heart attack, why have not similar successes in reducing the occurrence of new cases has been seen, especially in light when we have presence of well-established lifestyle and especially effective therapeutic options such as statin and aspirin. So in my opinion, among many others, a major contributing factor is that we continue to miserably fail in accurately stratifying cardiovascular disease risk by principally relying on traditional risk factors and surrogate biomarkers, for example, LDL and HDL. And as a result, we are unable to focus our preventive efforts in the group that is more likely to benefit from them. The reason I'm saying is a major limitation of this approach is that a sizable portion of patients who actually develop coronary artery disease do not have any such abnormal levels of these biomarkers. And on the contrary, a significant portion of those with multiple risk factors and abnormal biomarkers may actually not be at high risk. So, for example, as you can see in the slide 1 here, in nearly 26-year follow-up data from the Framingham Heart Study revealed that cholesterol levels, which are a major cardiovascular disease risk factor, but also a therapeutic target, were the same in 80% of individuals who eventually experienced myocardial infarction versus not. In fact, nearly half of those who had a myocardial infarction had normal cholesterol. Now, I can say that we can derive the same information for non-specific biomarker, for example, the high-sensitivity C-reactive protein. For example, in 2012, in a New England Journal paper, the emerging collaborators participant presented a pooled data of 52 prospective studies that included nearly 250,000 individuals who had no history of cardiovascular disease at baseline. Now, in a follow-up of nearly 1.5 million person-years at risk, what they found that addition of CRP minimally discriminated among those who will and not develop a cardiovascular disease, whereas the net reclassification improvement, which has now become the gold standard of measuring the value of any additive test on top of traditional risk factors, it was only 1.5%. The authors concluded that if all of these patients, especially at intermediate risk, were screened for high-sensitivity C-reactive protein, only 5% would be reclassified at a higher risk and thus eligible for statin therapy. And that would translate in preventing one cardiovascular disease event for every 400 to 500 individuals screened.
So can you tell us what alternative approaches might be recommended to accurately identify those at highest risk and those at lowest risk for appropriate cardiovascular disease risk stratification?
So, Nathan, one can argue for a paradigm shift in our basic approach in primary preventive CVD settings, that we shift the focus of using surrogate biomarkers to actual detection of disease process itself, which is atherosclerosis in this case. Now, in this regard, coronary artery calcium testing by non-contrast CT can be viewed as a matrix of disease rather than a surrogate biomarker. So in the last 2 decades, coronary artery calcium measurement has proven consistent as far as prognostication, discrimination, and reclassification of cardiovascular disease is concerned. Now, the most notable studies in this regard that has led the efforts are the multi-ethnic study of atherosclerosis, MESA, and the Heinz-Nixdorf recall, which both showed 9 to 16-fold higher hazard ratios for having a future cardiovascular disease event in the intermediate term, about 5 to 10 years, among those who had severe burden as compared to calcium score of 0. Now, not only this, these studies also showed significant net reclassification improvement with 1/4 of the whole population across the entire spectrum of baseline risk were appropriately reclassified based on coronary artery calcium testing. Now, in comparison, investigators from MESA demonstrated that unfortunately other risk factors as well as other tests, for example, carotid intermedial thickness testing, endothelial function assessment by FMD, and high sensitivity C-reactive protein, resulted in minimal or any improvement in risk discrimination, as well as the minimal improvement in reclassification. So, taking it to the next step, apart from its ability to identify those at high risk, among whom the majority of events will happen, in my view, the major strength of coronary artery calcium testing lies in its power of 0. So I would like to take your attention to the slide 2, where you can see in a series of studies that included a large meta-analysis, a large retrospective study, and also data from the prospective MESA study, that in a follow-up of almost 5 years, almost very few events were seen, event rates of 1 per 1,000 patient years, and that would translate into 1% 10-year event risk. So if we are able to use a strategy of identifying the low-risk individuals with coronary artery calcium testing, what it will do is enable us to focus on those who have actual disease, as they're the ones in whom majority of the clinical events will occur and are more likely to benefit from aggressive preventive therapies. This calls for more appropriate resource allocation.
So can you give us an example of the utility of coronary calcium screening for identifying those who may be most likely and least likely to benefit from lipid-lowering therapy?
Nathan, this is an excellent question. I would like to use the Jupiter study as an example. Briefly, in this study, we noted a 44% reduction among men who were aged 50 years and above, and women who were aged at least 60 years and above who had no prior history of cardiovascular disease. All of them had normal LDL less than 130, but an elevated high sensitivity C-reactive protein of greater than 2, where we compare with rovastatin of 20 milligrams daily. Now, based on the strong results from this study, there is a strong likelihood that this will form the basis of an eligibility criteria for lifelong statin therapy by our upcoming guidelines. And also, they have been adopted by the Canadian guidelines. In my view, one of the most interesting studies that has been published in the last 5 years, Michael Blaha from our group, aimed to address this very key question that you asked, that whether assessment of coronary artery calcium can help us identify those who will, and in my view, the most important, who will not benefit from statin therapy. So for this study, we included individuals in the multi-ethnic study of atherosclerosis who met criteria for Jupiter eligibility. Now, as you can see in the slide 3, nearly half of these individuals who would have met criteria for statin based on Jupiter had no underlying coronary artery calcium, whereas 1/4 of them had moderate to severe coronary artery calcium scores. Now, in a follow-up that was a median of approximately 6 years, almost twice than that of the Jupiter population, we noted almost negligible events in those with calcium score of 0. Whereas 75% of all events happened in the small group of those who had at least moderate amount of coronary artery calcium scores. When we further compared the outcomes with coronary artery calcium scores and CRP among those who could be eligible for the Jupiter criteria, that is LDL less than 130. As you can appreciate here, coronary artery calcium provided the same prognostic value across if the CRP was normal or elevated. Whereas once you are able to take into account the information of the underlying burden of atherosclerosis, no additive value of coronary artery calcium was noted. However, in my view, the most important finding of this study was that based on the event rates, when we aim to assess how many individuals we will need to treat to prevent one coronary heart disease event, we found that you will need at least 550 individuals will be needed if they had a coronary artery calcium score of 0. Whereas, on the other hand, if the study would have focused only on those who had any coronary artery calcium scores, the number would be around 42. Whereas if you want to be more effective and focused only on 25% of those who had calcium scores in the high range, that is greater than 100, the number needed to treat would have been extremely effective, about 19.
So those are really striking results, Khurram. What are your estimates from data you've published regarding the frequency of people who are identified based on more traditional NCEP guidelines and currently treated, but who may derive little treatment benefit versus those who are not treated and perhaps should be identified on the basis of such subclinical disease testing, such as by coronary calcium screening?
So Nathan, using our prior model based on the low-risk populations such as Jupiter, we also took the next step and asked the question whether coronary artery calcium testing can also provide us the same value in identifying a subgroup who are traditionally at a higher risk based on our National Cholesterol Education Program. And we presented these findings from the MESA study last year at the American Heart Association annual session. Now, briefly, what we found that these high-risk individuals based on the NCP criteria who would be eligible for lifelong statin therapy, a huge heterogeneity in the burden of subclinical disease was found. Let me explain that. Exactly 1/3 of these individuals meeting criteria for statin by NCP guidelines had no underlying coronary calcium. 1/3 of them had mild amount from 1 to 100, and 1/3 had greater than 100. Now, when we followed them up for a median of 7.5 years, we only noted 7% of all events happening in 1/3 of the group who had no detectable coronary artery calcium scores. Whereas 75% of all events happened in the same number of individuals, but who had a high coronary artery calcium burden greater than 100. Now, using the same approach, we also calculated the 5 years number needed to treat, where we applied a conservative relative risk reduction of about 30% by using a moderate dose of statin in each of these coronary artery calcium strata. So for those with coronary artery calcium score of 0, we estimated that we will need to treat almost 284 individuals to prevent one event in the next 5 years, whereas it would be as low as 25 if we had only focused on those who had a high calcium score burden. Now, secondly, we also highlighted the fact that a substantial amount of the study population, about 75%, did not meet criteria for statin therapy. Almost 20% of these individuals had very high calcium score burden. And their event rates were significantly higher, and we needed a much lower number needed to treat to prevent these individuals from having a future heart attack. So my take is that in this current environment where we're seeing rising healthcare costs, and at the same time, the resources are shrinking, I don't think we can afford to treat a large number of individuals just to prevent few events. It's very important that we improve our risk assessment abilities because what it will do is it will help us aim to target these intensive therapies to those who are actually at the highest risk, among whom the number needed to treat is small enough that will make prophylactic treatments such as statins and aspirin cost effective from a societal standpoint.
So finally, Khurram, what are the implications of your findings, and how might they impart decision making in treating or not treating high-risk individuals classified by actually traditional strategies versus subclinical disease testing, such as by calcium scanning?
Nathan, I think it's a very exciting time. I believe we are at a crossroad right now where emerging studies, especially from our group, is gathering enough evidence, which is challenging our current decision-making paradigm that is solely based on traditional risk factors, which determines the intensity of our primary prevention efforts. And I believe that such assessments are going to fall extremely short if relied too strictly for individual patient management. What we have seen is that for decades, our guidelines have developed consensus that all individuals that are considered at high risk based on traditional measures are equally at higher risk, and all should be aggressively treated. And for all of them, we should have stringent treatment goals. Now, our finding really confirms this assumption and asks, are all these individuals actually at a higher risk? And can we potentially identify a subgroup who may actually be at a lower risk and among whom we can potentially have flexible goals? However, at the same time, I want to assure that our findings do not dictate specific treatment paradigms. What our goal is to provide more information for shared decision making so that we can support the discussion among pertinent stakeholders who can look for alternate strategies for appropriate resource allocation. However, at the same time, I say that our studies do definitely provide the framework that should be considered for a paradigm shift in the manner how we risk stratify asymptomatic individuals and determine who is a good candidate for lifelong preventive pharmacotherapy. I sincerely hope that this will stimulate a debate whether a strategy that can separate a subset of individuals with no atherosclerosis and focusing only those among either with any subclinical atherosclerosis or a higher burden is the way to go, and in future studies, whether from a societal standpoint, would be cost effective.
So thank you so much, Khurram, for sharing your insights with us today on this very important issue. And I'd like to thank our CardioSource audience for your attention today, and hope you'll visit this new clinical community frequently for ongoing information about cardiometabolic disease. Again, this is Nathan Wong for the CardioSource clinical community on cardiometabolic diseases.
Thank you, Nate, and thank you to ACC for this opportunity.